We have already read till here. That was treatment of relapse. Now let's start with the congenital nephrotic syndrome. Congenital nephrotic syndrome, it is early onset nephrotic syndrome in less than 3 months. Then we can suspect that it's congenital, associated with other genetic disorders also. So it is NPHS1, NPHS2 and WT1. Let's see. These are the genes, okay? And NPHS1 codes for the nephrin, and inheritance pattern is autosomal recessive, and there is microcystic dilation of the proximal tubules. Now in NPHS2 there is podocin, which is autosomal recessive, and there is a pathology that is FSGS. WT1 gene, autosomal recessive inheritance is seen, and diffuse mesangial sclerosis. In WT1 gene, mutation is associated with a syndrome known as the Denys-Drash syndrome, which is characterized by ambiguous genitalia in male child and increased risk of Wilms tumor. Okay, what is seen in Denys-Drash syndrome? There will be ambiguous genitalia and increased risk of Wilms tumor. And WT1 gene mutation is associated with what? This syndrome. Okay. Along with congenital nephrotic syndrome. Now let's move ahead. Important terms in the nephrotic syndrome. First is frequently relapsing nephrotic syndrome. When we will term a patient with frequently relapsing nephrotic syndrome if more than 2 relapses in the first 6 months. Okay. After the diagnosis, if more than 2 relapses in the first 6 months, the child I was talking about, a 3-year-old girl child who came to us after 1 year. Okay, so she will not be diagnosed under frequently relapsing nephrotic syndrome. If more than 3 relapses in any 6 months, then also it will be called as the frequently relapsing. And if more than 4 relapses in 1 year. Okay, if more than 4 relapses in 1 year. Steroid dependent nephrotic syndrome. This was all about frequently relapsing. Okay, more than 4 relapses in 1 year. What are the 3 criteria? 2, 3 and 4. 2 in first 6 months, more than 3 in any 6 months, and more than 4 in 1 year. Now steroid dependent one develops more than 3 consecutive relapse while on alternate day steroid treatment or post 14 days after stopping the steroid treatment. Okay. So we know that we give 3 months of steroids in steroid dependent nephrotic syndrome, and if develops more than 2 consecutive relapse while on alternate day steroid treatment, right? In the first 6 months we give first 6 weeks we give daily steroids, and later we switch to alternate day steroids for 6 weeks. So if there are more than 2 consecutive relapse on alternate day steroid treatment, or this was one criteria for steroid dependent nephrotic syndrome, or post 14 days after stopping the steroid treatment, we give 3 months of total steroid treatment, and within 14 days if the child has symptoms again, then this steroid dependent nephrotic syndrome. Management of these two are alternate day low dose prednisolone in the dose of 0.5 to 0.7 mg per kg, fine, and daily in case of infection. If for 5 to 7 days infections can precipitate the relapse, right? If there is infection to any child diagnosed with frequently relapsing or steroid dependent, then we have to give daily low dose steroid. Okay, if the patient is able to maintain stable remission while on steroid, decrease the dose to 0.2 to 0.3 mg per kg for 6 to 12 months and then stop. If the patient was steroid dependent and we started giving alternate day prednisolone, but and there was stable remission was maintained, then we can decrease the dose of the steroid to 0.2 to 0.3 for 6 to 12 months. Despite treatment, relapse develop or threshold, then we have to use threshold becomes, I don't know what's written here, we have to use steroid sparing agent, right? I'm unable to read here. Let's start. Choice of the steroid sparing agent depends on, first is the threshold of more than 1 mg per kg, presence of features of complicated relapse, then only we have to start steroid sparing agent, And what is complicated relapse? Relapse with life-threatening complications like hypovolemia is present, or life-threatening infections like peritonitis or cellulitis is present, and thrombosis, that is increased fibrinogen, and low levels of the anticoagulant proteins are present. Okay. Most common cause of the peritonitis in the nephrotic syndrome is streptococci pneumoniae. There is peritonitis seen in the nephrotic syndrome. The child I'm talking about, last year when she was admitted, she was having peritonitis, but this time just edema and facial puffiness is present. Okay, so when we have to think about steroid sparing agents, if the threshold is more than 1 mg per kg, if there is complicated relapse with hypovolemia, life-threatening infection, or thrombosis. Fine, let's move ahead. If any of the above conditions are seen, then we can use MMF or cyclophosphamide. MMF is mycophenolate mofetil. Okay, these are the steroid sparing agents. If none of the above conditions are seen, then we can use levamisole or MMF. Now coming to steroid resistant nephrotic syndrome, no response to steroids even after using daily steroids for 6 weeks. Then it is called as at the dose of 2 mg per kg, the initial that we give daily for 6 weeks. No response to that, then we term it as the steroid resistant nephrotic syndrome. So remember the timeline. Okay, so to term a nephrotic syndrome as steroid resistant, we have to give steroids for 6 weeks. This is very important. Treatment: before starting the treatment, do renal biopsy in steroid resistant one. Okay, we do treatment via calcineurin inhibitors like tacrolimus is preferred. Tacrolimus is contraindicated in seizures and hypoglycemia. Now coming to live vaccines administration in nephrotic syndrome. If the steroids more than 2 mg per kg per day for more than 14 days used, avoid live vaccines for 1 month. Okay, if the high dose steroids are used for more than 14 days, then we have to avoid which type of vaccines? Live vaccines for 1 month after stopping the steroids can lead to immunosuppression and decreased production of antibodies. Why we are stopping is because there is immunosuppression, no? So there will be decreased antibodies production. If cyclophosphamide used, avoid live vaccine for 3 months. Okay, and if other agents, avoid live vaccine for 1 month. Recommended vaccines which should be given is pneumococcal vaccine should be given, that is PCV 10 or 13. Preferred conjugate is 13 valent, given more than 6 months of age. Second dose 8 weeks apart. Okay, varicella vaccine should be given in more than 15 months of age, 2 doses 4 to 8 weeks apart. And influenza vaccine should also be given more than 6 months annually. These are the recommended vaccines in children with nephrotic syndrome: varicella vaccine, influenza vaccine, and the pneumococcal vaccine. Right? Pneumococcal vaccine is given in more than 6 months of age, influenza also in more than 6 months of age, and varicella in more than 15 months of age. Influenza is given annually, pneumococcal is given 2 doses 8 weeks apart, and varicella 2 doses again 8 weeks apart. We can learn them. Okay. This was all about nephrotic syndrome. So let's see what we read right in this part. We started with the congenital nephrotic syndrome, right? 1 second. Yeah, congenital nephrotic syndrome. If less than 3 months, then we have to suspect the congenital nephrotic syndrome. WT1 gene mutation is associated with Dennis-Drass syndrome, in which there is ambiguous genitalia in male child and increased risk of the Wilms tumor. We saw what is frequently relapsing nephrotic syndrome: 2, 3, and 4. More than 2 relapses in first 6 months, more than 3 relapses in any 6 months, and more than 4 relapses in a year. Steroid dependent if more than 2 consecutive relapse while on alternate day steroids or post 14 days after stopping the steroid treatment. We saw alternate day low dose prednisolone was given for its management, and in case of infection we have to give daily. Choice of steroid sparing agent depends on, we saw, the threshold and any complicated relapse was present. Most common cause of the peritonitis in nephrotic syndrome is streptococci pneumoniae. If any of the above condition is seen, we have to give mycophenolate mofetil or cyclophosphamide. In steroid resistant nephrotic syndrome, we label it as steroid resistant after giving steroid for 6 weeks. and we have to do renal biopsy in steroid resistant patients, and calcineurin inhibitors can be used, that is tacrolimus and cyclosporin. Tacrolimus is preferred and it is contraindicated in seizures and hypoglycemia. Live vaccines need to be given, but if high dose steroids are given for more than 14 days, we have to avoid giving live vaccines for 1 month. Cyclophosphamide use, avoid live vaccines for 3 months, and any other agent, avoid live vaccines for 1 month. Recommended vaccines include pneumococcal, influenza and varicella. Thank you.